All right, so today we're going to talk about a recent article that was published in Hepatology, and it's a pretty common issue that we encounter in the practice of hepatitis C, and it's really about this question of fibrosis regression that happens after successful therapy for hepatitis C. So these are my conflicts of interest. And so the objectives of our talk today are first that participants can discuss the recent paper's findings on fibrosis regression and to list the rates of fibrosis regression. That's a commonly asked question by our patients. And then to know a little bit about some of the non-invasive tests that are available for fibrosis assessment and also predicting regression of fibrosis. So the study was published by the group in Barcelona, Mauro and colleagues, in the May issue of Hepatology. And there was a very nice editorial by Lupe Garcia-Sal. So just to give you a little bit of background, as many of you know, the liver is a unique internal organ that has the ability to regenerate. So people who have advanced fibrosis can actually have resolution of the fibrosis if the offending agent like Hep C or alcohol is removed. However, we know that there are certain stages of liver disease where there's no point of return. It's usually the decompensated cirrhosis, and we think certain kinds of folks with cirrhosis also do not have a whole lot of regression of their fibrosis. In fact, a recent study found that if they have a hepatic venous pressure gradient greater than 10 millimeters of mercury, then that is correlated with clinically significant portal hypertension. And in those cases, it's really hard for that fibrosis to regress, mainly because the septae that develop are super thick and just can't break up after the cure of hepatitis C. So the authors in this study asked, with many people being treated, especially patients with advanced fibrosis, and a lot of those getting cured, how is this going to affect the long-term surveillance for those liver complications like liver cancer and end-stage liver disease, and really is it necessary for everyone? So this is a fairly unique cohort. So first of all, these are all post-transplant patients. So none of these are pre-transplant, and they were followed from 2001 to 2015. All of them had been treated with antivirals and successfully treated. So they all had an SVR12. Interestingly, the majority of them were actually treated with interferon-based therapies. However, there was around 30 to 40% that received either a first or second generation DAA. And because these patients were post-transplant, it was fairly protocolized that they were getting routine liver biopsies before their transplant, before the therapy, and then at pretty regular intervals. So they have a lot of histology on these folks. And there were about 60 to 70% where, for a variety of clinical reasons, they had IR-guided biopsy. So at that point, they also got an HVPG measurement. And then starting in 2007, they added some non-invasive tests, the FibroScan, and then a blood test for fibrosis that we don't really use that much here in the States. It's called the Enhanced Liver Fibrosis, or ELF. But think of it as kind of like the European version of FibroTest. So these are the characteristics of the patients. They, like a lot of our Hep C patients, were around 3/4 male, and it was an older population because there were transplants, so the mean age was 61 with a range between 54 and 67. Almost all the patients were genotype 1, with the genotype 4 actually being more common than we usually see here in the States. And then these are post-transplant fibrosis stage. They excluded anyone who was F0 at baseline, just because they didn't think it would be ethical to continue doing biopsies on them. And you can see that about a third of the patients were already cirrhotic. And then over here is the 1-year follow-up liver biopsy. So a lot of folks are moving from the more advanced stages into the earlier stages. And on the subsequent slides, we'll go into more detail with that. But amongst the cirrhotics, the vast majority, 57%, were Child's Class A, with 43% being Child's Class B or C. So the first thing they looked at is fibrosis regression. And so in this figure here, black, the darker it is, the worse it is. So the black is F4, and at baseline there was a third. After 1 year, and these people were successfully treated, it was 20%. So that went down, And you can see they're starting to fill more of the F2, F3 ranks here. And that was highly statistically significant, this trend. So look at it a different way. Which groups were likely to get fibrosis regression? What you see here is that the cirrhotics had a much lower chance of having any kind of improvement in their fibrosis. So in this slide, only 43% had improvement from F4 to F3 or below, whereas the other groups, F1, F2, F3, it was in the 70% range, 70 to 80%. So overall in the cohort, there were 67% who had fibrosis regression, 31% were stable, and 2% had worsening. And amongst those with cirrhosis, only 43% had any kind of improvement. So I think this is really helpful for your patients who are getting treated. They want to know, hey, what's my chance that my liver is going to get better? I think if you had someone who's F1 to F3 at baseline, you could probably say it's about a 70% chance you're going to go down at least one grade. If you're cirrhosis, it's more like 40%. So the next thing they looked at is the liver stiffness test through FibroScan. And the numbers up here are the 1-year follow-up. And then on the vertical axis here is at baseline. So everything that I've put in gray represents at least a 1-stage improvement. So you can see there's a good number that where they're in this kind of transsectional cells here that there a lot of people are having at least a 1-stage improvement. So the median stiffness score went from 15.7 in the cohort to 8.2. So that's solidly cirrhosis to around an F2, F3. And the area under the curve was 0.65 to predict any biopsy-proven regression of fibrosis. So the next question they asked is, okay, say you have a patient who's cirrhotic at baseline, are there certain other tests, in particular looking at portal hypertension, that can predict who's going to, of those cirrhotics, is going to regress? And what this shows is that hepatovenal gradient, less than 70% of those people had improvement. They went from F4 to F3 or better. And then if they had a liver stiffness measurement of 21, then that also performed quite well. So those were good. The next stage was a type of staging on the liver biopsy, and it's not commonly used, but it has an inverse relationship here, and was also statistically significant. So next they looked at the accuracy of these non-invasive tests. The first thing they looked at, it was predicting post-treatment advanced fibrosis, so that's F3 or F4. And this is an ROC curve where the blue line is the FibroScan. So it performed quite well. So its AUROC was 0.9. And then the green line here is the blood test, the ELF, and it was 0.76. So I think this is consistent with what we see in the pre-transplant population, and not too surprising there. But then the next thing they looked at is, well, what are these, what's the value of liver stiffness measurements for predicting regression in those people who are F3, F4? And they used a cutoff of 10.6 and 14 kilopascals to rule out or rule in. And then for clinically significant portal hypertension as your endpoint, it's 11.3 or 23. So in the editorial by Lupe Garcia-Sau, she proposed this conceptual framework, and I think it's really helpful to kind of go through this. So let's go through folks who are pre-treatment, F0, F1, and F2. None of these people are going to have portal hypertension. They're not going to have fibrous septae, and most of these people are going to regress to non-fibrosis, so F0. And they really have no risk of decompensation. And these people you can pretty much discharge from your practice. Let's go to the other extreme then, a decompensated cirrhotic. So these are people who are going to have F4 obviously on their testing. They might have ascites or portal hepatic encephalopathy. Their hepatovenal gradient is over 12. We're going to have fixed septa. And these are people who really are still at quite a high risk for decompensation or developing HCC and need to be measured here. So then I think the orange area is these compensated cirrhotics, and they might be anywhere between F3, F4. If they have lower hepatovenous gradient, like 6 to 10, then there is a possibility that they're going to regress. I think the jury is still out. This study would seem to suggest that you might be able to discharge these folks from care. But in this group here, if there's any kind of high portal hypertension, varices, then it's a lot less likely that they're going to regress, and they are still at risk for clinical events here. So, in going back to the question, what is the point of no return? I think you could probably draw it right here for sure, and the authors in the study might suggest that this is the point of no return. Anything that has cirrhosis and high hepatovenous gradient. So the conclusions are that over 2/3 of patients, at least in this post-transplant cohort who achieved SVR, have fibrosis regression. It's lower for cirrhotic patients, 40%. And then if you were going to use some kind of proxy measures, hepatovenous gradient over 10 or liver stiffness score over 21 is associated with a lower chance of fibrosis regression. I think this study was encouraging that even those decompensated cirrhotics did have some fibrosis regression. It was 40%. And one of the, I think, more controversial conclusions of the study was that they said that liver stiffness tests can be used to guide you in the decision of whether you need to do long-term follow-up and monitoring. So I'm just going to end with some limitations, and we can open up for discussion. I think one of the major limitations is a post-transplant population. So you can't always extrapolate that to a non-transplant population. It's a much more rapid progression overall. They have a lot of other immunocompromised states that are going on. There's only 1 year of follow-up. And then the subset of patients with cirrhosis who have regression was only around 30 or 40. And they really didn't fully elucidate what are some of the factors for regression in that population. We also don't know a lot about hepatocarcinogenesis, like what causes liver cancer, because we know it occurs in F3 patients, and we just really don't know what is it about them that puts them at risk for getting liver cancer. And also in this study, the liver stiffness measurement would have missed 18% of the patients with advanced fibrosis on that screening. And I think that's probably a little too high for my comfort level. So I think we just need a little bit more data, and we need it in different populations. But I personally am not going to change my practice from this. I'm not going to do more, FibroScans post-treatment. I'm going to keep on monitoring like I am. But I am open to suggestions and other opinions about that. I'll see if there's questions or comments about this paper.